Finally, we're united in a mission that we need to improve the treatment for myeloma patients everywhere, and that we don't rest on the status quo. And although we appreciate all that's been done, we're all very eager to do better. We have a large patient population here.
Welcome, everybody, to our next episode of Multiple Myeloma Patient Connect podcast. Today, we have an extra special guest, Dr. James Hoffman from the University of Miami. I will introduce Patient Connect and then hand it over to Dr. Hoffman to talk a little bit more about his work and the impact to the multiple myeloma community. So just in a quick nutshell, I'm Noose from Patient Connect. I work on patient engagement and awareness. What Patient Connect is a map that helps patients connect with people and places that can help them in their journey to get better support and care, right? And so we have a map. We have over 1,000 multiple myeloma patients on this map already. We just launched a couple of months ago. We have over 8,000 multiple myeloma patients within the multiple myeloma warriors community. And so this community is large and growing, engaged, active. We hope to see you on there, and so you can tell your patient story and connect with wonderful people and institutions like Dr. Hoffman over at University of Miami. So with that, I will now introduce Dr. James Hoffman. Dr. Hoffman, can you tell us a little bit about yourself and your background?
Sure. Happy to be here. Thanks for inviting me. So my story is I grew up actually in South Florida and lived here for the early part of my life. Went to New York for college and medical training, and that culminated with a fellowship at Memorial Sloan Kettering in New York. And there, entering my second year, I met Dr. Ray Comenzo, who served as my mentor in the field of multiple myeloma and amyloidosis and related conditions, and learn from him how to conduct clinical trials, how to treat patients with myeloma, how to think about myeloma. And then upon finishing fellowship, I came back down to South Florida, hoping to elevate the care of myeloma patients down here.
Excellent, excellent. And why multiple myeloma in general?
So there are a couple of reasons for that. And in medical training, we're all ultimately influenced by the people we meet, and certainly just coming across a mentor like Ray Comenzo, who's just the consummate physician scientist. That certainly played a role. But in terms of the disease itself, I found myeloma to be unique in a lot of ways. It's a very heterogeneous illness. Every patient's disease is different than their neighbor's disease. It's a field where a lot of resources are being poured into it. So the developments are kind of fast and furious, and treating patients in a disease space like that is incredibly gratifying. Always having something new, having something hopeful. So I found the pathophysiology of the disease very fascinating. I found the research very compelling, and I had a wonderful mentor who kind of put that all together for me.
Perfect. Makes perfect sense. So speaking of research, maybe you could talk a little bit about the research that you're working on, clinical trials that you're running, and what is impacting the patients in multiple myeloma.
So I'm very lucky to be part of a really great team here at University of Miami in terms of clinical research. And we have very wide-ranging research going on here, but to kind of talk through some of the highlights, we're very focused on an assessment of something called genomics, which is kind of a deep dive into the genetics of the myeloma cells, particularly trying to predict disease behavior, trying to predict who with pre-myeloma illnesses like MGUS or smoldering myeloma will ultimately develop myeloma, and ultimately how to personalize approaches based on individual genomic variables. So that's kind of a huge pillar of our research. A second major emphasis is on something called minimal residual disease assessment and how that plays a role in patient care. And for those that aren't familiar, these are methods either through bone marrow or blood work to detect tiny amounts of myeloma, too little to be detected by the standard myeloma labs. And by using these analyses, we can sometimes, or at least we're evaluating whether we can use these analyses to adjust therapy, to stop therapy in patients who are MRD negative for some prolonged period of time, or to potentially escalate therapy in those who don't achieve that outcome. And then third, we have a very wide-ranging clinical research program aimed at bringing new therapies or improving upon old therapies for myeloma, starting from newly diagnosed to multiply relapsed, targeted therapies, immunotherapies, combinations of the newest immunotherapies like CAR T and bispecific. So we want to really have a portfolio for any patient that comes here to have something compelling to offer them.
Got it. Excellent. So, what are some of the challenges in your research? And then also related, what are some promising new therapies, that you're most excited about? So, challenges and innovations that you're seeing.
So yeah, so I mean, I think in terms of challenges, it's kind of a good challenge in the sense that I think our biggest hurdle here is how to navigate all of the new therapies and how to kind of order them and how to kind of, triage them. And I think from the perspective of the patient, this is particularly challenging because, it's I sometimes talk with patients. Sometimes when you go to dinner, you just want to be served dinner. You don't want a buffet. You don't want to have to choose, especially when you feel like maybe the doctors know better. So why are you getting choices? And
Mm.
yet on the, to be realistic, there are choices. There are different approaches in different centers. There are different emphases. And so I think we're kind of stuck in a place where we have a lot of really good options, but we really need to understand better how to use them, how to order them for the best patient outcomes. And in a world where there are a lot of clinical trials being reported all over, uh,
Mm.
some of which started several years ago, some of which are more recent, having to figure out how to apply this research, how to apply the results into the clinic, I think is become a big challenge. And in terms of the promising therapies, I think that the immunotherapy approaches of the modern myeloma therapy, bispecifics and CAR Ts, and again, for those that aren't familiar, these are two ways to engage a patient's own T cells, part of the immune system, to fight their cancer. The bispecifics and the CAR Ts have really revolutionized the relapsed setting, and we can see incredible results in patients that have failed multiple therapies. And I think what becomes promising about that is, well, if we bring those therapies earlier or perhaps combine them in thoughtful ways, perhaps we can get such deep responses in myeloma that we can even start to talk about that cure word, which we're all so eager to get to.
Absolutely, absolutely. So, doctor, one of the things when I talk to patients as we're building out our map and our community is about how the different institutions really sort of are different in how they approach their treatments and how there's no sort of like set standard of treating multiple myeloma across, the country or the world. So maybe you can talk a little bit about University of Miami and your specific approach there, and how it's different than other places.
So yeah, no, that's a very good point. I mean, at the University of Miami, we definitely, we have several different myeloma treating physicians. And of course, all of us will have some subtle differences on a case-by-case basis, but we're very united on a high level, which is we feel that the majority of patients should be started with four-drug therapy, including daratumumab, lenalidomide, dexamethasone, and a proteasome inhibitor, bortezomib or carfilzomib. I think we're all kind of unified that the quad therapies or the four-drug therapies should be offered to most patients or those that we think that can tolerate those. We're united in an approach that stem cell transplant is still a valuable therapy for myeloma patients, but doesn't have to be applied to everybody and is a therapy that has pros and cons and should be weighed on a case-by-case basis. And I think we're all very united in the concept that the novel immunotherapies offer dramatic promise, and perhaps by using an MRD guided approach to get the very, very best responses, we can have patients on minimal to no therapy for long periods of time. And I think finally, we're united in a mission that we need to improve the treatment for myeloma patients everywhere, and that we don't rest on the status quo. And although we appreciate all that's been done, we're all very eager to do better. We have a large patient population here. We're the kind of really the sole academic myeloma focused center in South Florida, which is a huge area. And so we feel a big responsibility to kind of help lead the ship here to get patient outcomes where we all want them to be, which is that patients are outliving their disease or being cured of their disease.
So when we think about the goals for your department and the this work in multiple myeloma, can you mention any of the goals that you guys have? I think you just did in a way, but also any partnerships or collaborations you guys use to work towards those goals. Yeah, any mention about that?
Yeah, absolutely. So yeah, we definitely, the more we can work with others, the faster progress will happen. So we have a lot of important collaborations. I mean, certainly many of our large clinical trials are opened at multiple centers, and we each rely on each other to accrue the right patients with rapidity so we can get results fast. Some of our investigators, including Ola Langren, who runs the myeloma program, came from New York and Sloan Kettering, and there were certain collaborations there at NYU, still at Sloan, and otherwise, in terms of some of the genomics work that we're doing, et cetera. Um, I have a particular focus on a sister disease to myeloma called amyloidosis, and in that regard, have research that's ongoing and collaborations that are critically important because it's a more rare disease than myeloma. So to make meaningful change, we certainly need to team up.
Great. Yes, and incidentally, that's also how I got connected to Dr. Hoffman through one of his patients who, had nothing but the best things to say about her experience in multiple myeloma as well as amyloidosis. Dr. Des, who I've done a podcast with, so you can click right here and watch that podcast as well. Doctor, quick question about how you see the field of myeloma research evolving over the coming, let's say, 5, 10 years, and what role you and your team hope to play in that.
Yeah, I think the next great mission is to use these new technologies like MRD to as a goal and sustained MRD negativity potentially as a surrogate endpoint for either long-term disease control or even theoretically cure. And let me take a step back. One of the good problems we have in myeloma is if you run a clinical trial, compare two different treatments, well, it's going to take you a really long time to know if one treatment is better than the other because people are living for a really, really long time. So that's wonderful because it means we're doing a great job with patients, but it makes it a little bit harder to advance things, especially if you're waiting for a survival signal between the two treatments. So something like MRD, which you can assess very early, program A versus program B, which one gets to deeper MRD, I think that allows us to accelerate the pace of progress. And I think the goal has got to be utilizing a surrogate endpoint like MRD to kind of aim for the stars and potentially, get to a place where people are being cured of myeloma. In some cancers like Hodgkin lymphoma, when you give the right treatment, a large percentage of people, every last cancer cell basically is eliminated and the patients never relapse and they live their whole lives. Myeloma, unfortunately, even with the best treatments historically, there always seemed to be at least a little bit left, and recurrences could happen even years later. We want to get past that hurdle. We want to find out what combinations of therapies at what times can turn this into a curable disease, and then aim to cure the most people possible. I think if we had had this discussion 5 or 10 years ago, a lot of this would have been hopeful thinking and a little bit sci-fi, but now we're at a place where we can see the types of results in our patients that lead me to believe that we can be on the doorstep of kind of getting there.
Excellent, excellent. Oh, hold on. Yes. So when we think about the future there, are there any personal insights in terms of like patient stories or breakthrough moments that have impacted or influenced your work, that are bringing you to see the future in a certain way and pushing you forward?
Yeah, no, absolutely. There are many. But one that comes to mind is around 5 years ago at this point, I was referred a patient from a doctor that I share patients with who had myeloma that had failed conventional therapies, and she was considering enrolling in hospice. And she came to see me for a second opinion. Incidentally, she had the same birthday as me, not the same year, but the same birthday, and we bonded very quickly. And we were able to enroll her on, at that point, what was our first bispecific or BITE therapy program. She was the very first patient enrolled. And needless to say, she went right into remission. That remission lasted for about 4 years with excellent quality of life. the referring doctor, I think, thought I was a wizard in what I did with this. And it was incredibly gratifying. And then around 2 years ago, she had a slow recurrence and was able to get on another clinical trial with a new immunotherapy that's still not yet approved. And she went right back into remission, and she remains that way now, maybe 6 years after we first met when she was going to enroll on hospice. And to me, she's emblematic of the era that we're in, where patients can do well enough to get to the next big development and then jump on that train and hold on and get to the next train. So this provides real hopefulness for me, who sees a lot of myeloma patients, and I know it does for the myeloma community as well, that the available options to them are not just the things they can Google now and hear from people that they already got, but the stuff that's right around the corner. And I think it gives our patients the hopefulness that, again, they can outlive this disease and live normally. And that's just incredible. Treating myeloma patients a decade ago certainly didn't have that same feel.
Got it. Got it. So if I hear you right, hope and options, is really the advice that you would give to patients and their families who are navigating these complexities.
Yeah, absolutely. We don't sugarcoat. This is a frightening diagnosis. No one wants to be sitting in front of an oncologist. No one wants to be Googling prognosis and everything else. And so
Right.
we don't minimize the trauma that patients go through. And it remains to this day very traumatic, like any major diagnosis. They hear the word incurable, and it's very overwhelming. But I really want to counter that with a very realistic, not lottery odds, wishful thinking kind of reality, that we're in a time where we don't even really know the prognosis of newly diagnosed myeloma, because we expect it to be so much better than looking in the retrospectoscope, looking backwards. So I think that what we can try to do for our patients is temper some of that fear and that overwhelming sadness, and with a real truthful hope. And when I get to see a patient come in and their family with that intense fear and concern and leave at least feeling like we got a plan, we got a team, we have hope, that is one of the best parts of my job.
Love that. Love that. So as we think about, the patient centricity, right? And the holistic overall well-being of the patients, in addition to all the advanced treatments that you've talked about, right? How does your institution, and how can patients in general just be better supported holistically in their overall well-being? What are their options? How should they be thinking about holistic well-being?
Yeah, I think that's really, really important because, patients can find a lot of excellent doctors that know what medicines to prescribe. But myeloma is not simply a disease about how many myeloma cells are there at the moment, what is the M spike, what are the light chains. Those are all critical variables, hematologically speaking, in terms of how the disease is doing. But this disease is in a part of a full human being that has a lot of elements to their life, physical, emotional, spiritual, etc. And this is a disease that hurts people. So when they come in, there can be pain, there can be disability, there can be fatigue, there can be anxiety. And so I think to treat people holistically, what you really want to get is a program that can handle all of these elements of your life. And so at Sylvester, University of Miami, we're very lucky. We have an excellent pain service. We have an excellent psychology and psychiatry service. We have a myeloma dedicated nutritionist. We have ancillary support like acupuncture, music therapy, etc. We have pharmacists that do nothing but focus on multiple myeloma. We have nurses and nurse practitioners that do nothing but focus on multiple myeloma. So I think when you get treated in a program like ours, and I'm very proud of our program, we treat the human being in his or her entirety. And I think if you're being treated without those elements, something can definitely be missing.
Got it. That's fantastic. Doctor, you specifically are very good with sort of patient feedback and advocacy. I, was just on a support group meeting with you the other day in the Palm Beach multiple myeloma support group meeting, and you were, taking questions from all the patients on there. And so you're very outspoken, and an advocate. So appreciate that and want to understand sort of how do you incorporate patient feedback like systematically, in your research and your treatment strategies.
Yeah, so thank you for that. I'm doing another support group next week. I think those are hugely important. We're lucky to have a lot of wonderful support groups that are nearby here. And patients, it's one thing to hear something from their doctor, it's one thing to read something on the computer. But when you have someone sitting next to you that's gone through this, maybe is a year ahead of you in their course with myeloma, those bonds are so critical, and support groups are so important. So yeah, certainly we have elements of feedback for our program at large in terms of patient satisfaction with their visits, with everyone they encounter, et cetera. We incorporate quality of life assessments in almost all of our clinical trials. We understand that if we give medicine to a person and their myeloma parameters get better, that might excite us. But if they feel twice as bad related to the side effects or the logistics or financial toxicity, financial burden, then we're not doing them any great favors. And so we very much incorporate, or we try to incorporate, the patient experience, patient perception into really all of our decisions. I think that when you're dealing with a variety of different medical choices, each with their own potential side effects, their own schedules, their own logistics, their own copay concerns, what I always tell my patients when we meet early on is, listen, this has got to be a 50-50 partnership, because you expect me to know the disease best, and I know that you know you best. And so the only way this works is if we meet in the middle. And I think that all of the partners I have in my group approach this the same way, which is we want to understand the priorities, the preferences, the background of the person that we're dealing with. We want to develop a relationship with that person, because only in doing so can we do the right thing for each person, separate, different from doing the right thing for myeloma patients at large.
Excellent. And so when we think about, I love that 50-50 partnership. I mean, I think that makes perfect sense. And thank you for describing that. When we think about support groups and patient communities, right? How do you encourage their involvement, or what do you think needs to be done better at scale for that interplay between the group versus the person, which you just mentioned, and your one-on-one relationship with them, but rather the group, the community? How can there be better and more connected relations? What do you see out there?
Well, I think the work that you guys do is really kind of part of the effort to elevate that to where it needs to go. Certainly, local support groups and even kind of national groups do a really good job bringing people together. I think when they're done right, everyone benefits. If you do it kind of very haphazardly, you can have people asking questions that are just scaring everybody else, or kind of certain, these meetings can go in a direction that's not totally helpful. But when really done the right way and professionally and professionalized, as again, you're trying to do here, and I know you guys are already doing a lot, I think this makes all the difference, because patients are therefore getting information that's timely, that's correct, that's in lay speak, that they're ready for in their phase of the illness. They're not just kind of getting overloaded. Allowing that kind of back and forth, allowing a patient to kind of connect and then back out, and connect and then back out. I think that's really what's needed, because like I said, every myeloma patient's different. Everyone is at a different point within the course of their lives and disease, and forcing the patient to find other people on their own, or to find a patient forum on the internet. These are very, very perilous. I sometimes tell my patients, if you Google, how are you doing with myeloma, and you see somebody blogging about it, the people that are writing about it online are the ones that are having the toughest time. If they're feeling fantastic, they're at the beach or they're working. So it's a very kind of selected group. So I think, like I said, kind of formalizing this on large scale is so important, so that patients get the right information in the right way.
Excellent. Excellent. And doctor, thank you for that. I think we will conclude here, but folks, if you want to follow Dr. Hoffman, we're going to link to his Twitter or X account here. Also, you can check out the Sylvester Comprehensive Cancer Center over at the University of Miami and his team. that link is available in the Patient Connect map if you search University of Miami. So we want to thank Dr. Hoffman for all he's doing, and truly his advocacy and interplay with multiple myeloma and amyloidosis communities, really something different. And we thank you on behalf of the full community.
Very, very kind of you. I appreciate it, and I appreciate all the work you're doing.
Thank you, Dr. Hoffman.